Welcome back to Mayo Clinic Radio. I'm Tracy McCray, along with my guest now, Dr. Jon Ebbert. According to the National Survey of Drug Use and Health, about 21.5 million Americans adults battle with substance use disorder. About 80% of those individuals struggle with alcohol use disorder. Alcohol use disorder is the third leading cause of preventable death and disability in the United States after tobacco and obesity. And here to talk about alcohol use from a primary care perspective is Dr. Jon Ebbert, our co-host/guest. Welcome to the program, Dr. Ebbert.
Pleasure to be here.
What exactly is it that you think is of interest?
So I'm a primary care provider and an addiction specialist. And a lot of times in primary care, I am seeing patients who are coming in and they report alcohol use to me, and it appears that their alcohol use is fitting into what I would consider to be risky use behavior. And somehow it's been normalized. So what's interesting about that is the NIAAA, which is the National Institute for Alcohol and Alcoholism, has said that risky use is greater than 14 drinks per week for men and greater than 7 drinks per week for women. And I have had many women come and report to me that they're in the risky use category and they think it's quite normal. So it's interesting to see that disconnect there.
All right. So that 21.5 million Americans, you think, from what you're seeing in your offices, you think that is probably an accurate number?
Yeah. So the statistics out there are suggesting that about 80% of the individuals struggling with substance abuse in this country are struggling with alcohol use disorder. And I really think you need to think about it like a pyramid. 2/3 of the U.S. adult population consumes alcohol. About 25% of the U.S. adult population binge drinks, and that's drinking more than 5 drinks in a 2-hour period for men or 4 drinks in a 2-hour period for women. And about 5% of the population has alcohol use disorder, which is really heavy alcohol consumption that's associated with adverse health consequences or adverse legal consequences or adverse social consequences.
Well, how do you know when someone has a problem? Because for one person's 2 drinks can be equal to another person's 6 drinks, depending on how much they drink, right?
Right, exactly. So there's so you'd bring up an excellent point.
Well, and then what is the problem also? We're not talking about someone who can handle their liquor. That's not what you're talking about, right?
Right. So the reason why the NIAAA defined risky use as that cutoff of greater than 14 for men and greater than 7 for women is it's been suggested in good epidemiologic studies that alcohol consumption at that level, although seeming not to cause any significant social or psychological or legal problems for the patient, actually is associated with significant adverse health consequences. And I think we were just talking about the rising rates of liver cirrhosis in this country, which is related to alcohol use.
65% increase in deaths from cirrhosis.
And that's remarkable. That is remarkable. Alcohol is very normalized. I think we were talking before the show about how now we're having sparkling water with alcohol in it. And this is all being normalized. And I think it's a huge, huge problem.
It's also interesting to me, because if you're someone who likes to just enjoy sparkling water, with ice cube in a glass, then all of a sudden, hey, there's a product now that is an alcoholic drink, what I normally drink in a glass. And is that, in my head, someone who has an alcohol problem is not drinking a sparkling water alcoholic drink. Or maybe I'm just being incredibly naive.
It has to do with it's a question of quantity frequency, and most people would agree that a problem is a problem when it's a problem. So if I'm consuming sparkling alcohol beverage, and I'm not having any social, legal, or personal consequences from that, it's really not a problem. But the NIAAA and I think our epidemiologic evidence would suggest when that exceeds a certain quantity per week, it actually increases the risk for adverse health consequences. And the problem with alcohol, as you pointed out, is you develop tolerance. So there are a lot of people walking around with functional alcoholism where they're drinking a large quantity of alcohol just so they can control the jitter so that they can go to work. And these are perfectly normally functioning people.
I'm glad you're here because you can answer this question. And it has to do with, I'm just going to put both of us in the same camp here. When we were college age kids, when we were 21, because of course we would not have drank any alcohol before that age, there was no caffeinated alcohol avenue unless you had some sort of, I don't know what, poured into your coffee.
Right.
But now, college kids with like Monster energy drinks being used as a mixer. I am curious, there has to be a whole new generation of people who are drinking alcohol that is the alcohol that they drink. Not just one of them. That is what they are drinking, are those Monster drinks.
No question. And they're incredibly dangerous. And the danger is because they are able to consume higher levels of alcohol in the presence of caffeine than they otherwise would have consumed, because they would have passed out long before when they didn't have, if they hadn't had caffeine in there under ordinary circumstances. So they're consuming high levels of alcohol. And the other thing that's dangerous is when they get in their car, they feel like they're doing fine. The caffeine wears off, but the effect of the alcohol lingers and they become impaired again. And so it is incredibly dangerous. And I think that's the reason why you're seeing some of these dramatic increases in liver cirrhosis, because of the binge drinking that's going on. You can drink a lot of alcohol in a very short period of time because you're caffeinating it and you just don't feel as impaired.
I didn't even think of that, you said the caffeine wears off before the alcohol does. Huh.
Yep.
Wouldn't even thought of it.
Yep. And you have a misperception of impairment. There's a fascinating phenomenon in alcohol use where when someone's blood alcohol level is rising, that when they first start drinking, when their alcohol use is rising, it gets to a certain point where they feel impaired, and then they sort of develop tolerance to it. And when the blood alcohol is the same level when the alcohol level is going down, they feel significantly less impaired. So you develop short-term tolerance for alcohol. So at the same alcohol level, you are feeling not impaired during an acute episode of drinking. And I think it explains a lot of the problems that people are seeing right now with increased car accidents, increased liver cirrhosis, is that short-term tolerance.
All right, so let's talk about treatment. Are there medications available that can help people? I mean, those medications make you not want to drink. Is that what's happening?
So, yeah, and I think that's a really great question of where does medication fit in therapy? And what happens is when patients come in, if they feel that alcohol is a problem and you offer them medication, they say, well, what's the medication going to do to me? In the old days, we had Antabuse or disulfiram that would make them vomit. Mm-hmm. Now we have medications that like naltrexone and acamprosate. Those are two medications that work through different mechanisms. And what it essentially makes patients who take it feel like is that it's just that the alcohol is not as reinforcing. And when you change the drug use experience from consume alcohol, feel high to consume alcohol, feel nothing, it's easier for you to extinguish that behavior. So those are two drugs that we have available, and they need to be wrapped in some sort of comprehensive program where you're also providing, mutual help through in psychosocial support as well.
Does medication like that work for other addictions, like a food addiction?
It's a great question. To the extent that the other food addictions might be driven by an opioid mechanism. So the way naltrexone, for example, works is it blocks the reinforcing effect of alcohol by blocking a mu opioid receptor. So it may. It's a great question.
What should a family member do or friends do if someone is struggling and needs help?
This is the hardest thing we see in clinical practice, right? We have patients who come in with spouses of our patients and they're concerned about alcohol use. Obviously, it becomes part of a family dynamic. I think we obviously don't want to advocate that patients put themselves in any danger, but I think gentle suggestion or sometimes family interventions or, professional counselors can be effective, but really at the end of the day, the alcohol user has to want to change. The nice thing is that some of the most effective treatment are these mutual help groups like AA. And those are easy to attend because they happen pretty much every day in every city. So I think that if, it is a very hard thing, but I would say talk to your physicians, talk to your providers and see what sort of assistance and opportunities there may be to bring that patient along toward accepting treatment.
We've been talking about alcohol use disorder with Dr. Jon Ebbert. Thanks so much, Dr. Ebbert.
It's a pleasure to be here.